a bit here. I'll reassure you that a lot of the concepts here I'm trying to just introduce them to you so you've heard them once before, but you absolutely will not get a deep understanding of these unless you go through the assignment and discuss it in your small groups. So some of these concepts may not quite ring true. I'd ask you to just be a little bit patient and see how this goes over the course of the next day or two. And if after a couple of days and after things sink in and after you get the answer key back, it's still not making sense, then we can absolutely tackle it again and try to deepen your understanding. But just keep in mind that the next 50 minutes or so are going to be rapidly going through the rest of the materials here. So, and you all should hopefully have your clickers as well. If you don't, grab one from the back. So as we looked at this 2x2 table, you saw that I labeled things as true and false, positives and negatives. What we do then is that we use these numbers from a single diagnostic study, which is essentially a cross-sectional study with a categorical variable state. Just keep that in mind. Remember we were talking about continuous and categorical variables last week? These are categorical variables because you're labeling them as either having a disease or not and testing positive or not. In order to combine these different test findings, you'll find that we'll be combining them in test characteristics. And the definitions are that there are two test characteristics which are dependent on the prevalence of the disease in the study that was done, and there are two test characteristics that are completely independent of the prevalence of the disease in the study that was done. Remembering the concept of prevalence from last week's lecture with Dr. Gruber. The prevalence-independent characteristics are sensitivity and specificity, and the ones that are dependent are the positive and negative predictive values. And if I could introduce the concept that these two, if you understand the difference between these two, you now understand the difference between patients and populations. And you will understand the relationship between the two and why we call this course the way it is. And I'll return to this as we go through the rest of our talk today. So let's do some basic definitions. The first is sensitivity. You just have to know this, and don't keep in mind, we're introducing it now, you'll practice it. We're also going to introduce it in other courses as well. So the ID course later on this year, next year you'll be hearing this, and as you dive into the literature, you'll see these terms over and over again. Sensitivity is just defined as the probability that the test will be positive when the disease is present. And basically that's written as the probability of the test being positive given the fact that the patient has the disease. Remember, having the disease is labeled by the accepted gold standard at that time. Another way to say it is that of all the people with the disease, it's the percentage of those people that test positive. Another way to think about it is that a sensitive test is one that will detect most of the patients who have the disease. In other words, it will have a low false negative rate. The false negatives, remember, are ones where the test is negative, but the patient actually has the disease. If the false negative rate is low, then your sensitivity will be high. You will have a very sensitive test. This will make sense as you look at it visually on the 2x2 table. So for those of you that are visually oriented, I encourage you to do that. Specificity is the opposite. Specificity is basically stating it's the probability that the test will be negative when the disease is absent. In other words, what is the probability of the test being negative given the fact that the disease is not present as measured by the gold standard? Another way of saying it is that of all the people without the disease, what is the percentage of those that will test negative? Conceptually, basically it's stating that a very specific test is one that will rarely be positive in patients who don't have the disease. In other words, you'll have a very low false positive rate if you have a highly specific test. False positives are those that are falsely labeled as having the disease when they really don't have it. And if that number is low, you will have a high specificity. Predictive values, however, focus on the patients. You'll think about that. If you think about sensitivity and specificity, you might ask, well, if I was a patient, I may not actually be that interested in a particular, that sensitivity of the test characteristic. So if sensitivity is of all the people with the disease, the percentage testing positive, and you tell a patient, well, this test has a 93% sensitivity. If you had the disease, you would be 93% likely to test positive. Well, the patient's still sitting there saying, well, do I have the disease or not? You're saying if I have the disease. That doesn't really help me. Well, at a patient level, predictive values help. Because predictive values basically state what is the likelihood that I have the disease given the fact that I either test positive or negative. Positive predictive value basically says what's the likelihood that I have the disease given the fact that I tested positive on a test. In other words, what is the probability of the disease being positive given the fact that the test is positive? And the negative predictive value is what is the likelihood that I don't have the disease given the fact that I tested negative. So I come into your office as a clinician, you got the test on me, you got the VQ scan on me, and it was normal. Okay, doc, does that mean I don't have a PE? That's what the negative predictive value would be answering. Or, holy cow, I have a positive test. Does that mean I do have a PE? Keep in mind that the answer to those questions is usually not 0 or 100%, because we're using a VQ scan, which is not the gold standard. And almost exclusively in our practice, we are not using gold standard testing. So the predictive values are helpful for the patients. The sensitivity and specificity are helpful for the populations. And you'll see why that manifests. So basically, if you look at the 2x2 table, it should make sense how these calculations emerge. Sensitivity, of all the people with the disease, the percentage testing positive. That's A over A plus C. Specificity, of all the people without the disease, this column here, the percentage testing negative. That's D over B plus D. The predictive values are reading across the table as opposed to up and down. Positive predictive value saying, of all the people who tested positive, what percentage of them actually have the disease? If I tested positive, what's the likelihood that I had the disease? Well, it's A over A plus B. Negative predictive value is stating that if I tested negative, this bottom row here, what is the likelihood that I really don't have the disease? Well, it's D over C plus D. The reason why it's not 0 or 100 is because B and C are not 0. There are false positives and false negatives in any test that's not the gold standard. That is part of the uncertainty of making diagnostic decisions with our patients. So the question to ask, remember I started out by saying that sensitivity and specificity are prevalence independent and the predictive values are prevalence dependent. The question you should be thinking about is why? Why is that the case? Well, we're going to spend the rest of our time answering that question. So in order to understand that, let's try it out with our case now. So now we're talking about this VQ scan, and we did our diagnostic question formulation, and we found this study in the literature. And here's the study. To determine the diagnostic performance of VQ scans for the detection of a pulmonary embolism, a study was conducted where 300 patients underwent both the VQ scan and the gold standard pulmonary angiogram. Remember, they have to go through both, all 300. In that study, 150 of the patients were found to have a PE by PA-gram. So 150 out of those 300 were found to be disease positive, right? Because the gold standard said they were. Of those 150, 75 patients had a high probability VQ scan, meaning a positive test on the test of interest, the VQ scan. But of the other side, the 150 who didn't have a PE, 125 had generally a normal VQ scan, or we're going to call that a non-high probability one. Let's just say there are 2 test results in a VQ scan. Caveat, for those of you that know more about pulmonary embolism, you'll know that VQ scans don't have high and non-high. They have high, intermediate, low probability, indeterminate. We're going to ignore all of that, and we're going to lump everything that's either a medium probability, low probability, normal, or indeterminate into one category called non-high. So you either have a test that's positive for VQ or it's negative. Okay? So now what do we do with these numbers? Well, we put them in a 2x2 table. Remember we said that 150 had it and 150 didn't by the gold standard? That means the sum of the first column should be 150. These are the people that had the disease, and the sum of the second column should be 150 as well, because there were 300 patients total in the study. That should be fairly straightforward. You also were told that 75 of these patients had a high probability VQ scan. You were also told that 125 of these patients who didn't have the disease had an other result on the VQ scan. So those form your true positives and your true negatives. That's where the test and the gold standard agree. However, based on the numbers, you can tell, and you can back calculate and find out that there are 75 patients that were falsely negative. They were labeled as having not the disease by the VQ scan, but they truly had it. And there are 25 patients who had a positive test, but didn't really have the disease. These are your false positives, your false negatives. Right? Fairly straightforward so far. Should be easy to calculate. You should be able to do this. This is a fundamental part of your assignment as well. Now what? Well, now we got to calculate the sensitivity and specificity. This is fairly straightforward. I gave you the formulas for this. But keep in mind that now that you got the numbers, you should be able to do this. You can find out what the test characteristics are for this study. Of all the people who have the disease, the percentage testing positive. That is your sensitivity. Therefore, your sensitivity is 75 over 150 or 50%. Of all the people who don't have the disease, the percentage testing negative, you know that number. That's 125 over 150. That is 83%. You also can determine your positive and negative predictive values. Of all the people who tested positive with the experimental test, the percentage that actually had the disease is 75 over 100. 75%. You can do the same for the negative predictive value, which is the percentage of people, of all the people who tested negative for the test, the percentage that truly didn't have the disease. That's 125 over 200, which works out to about 62.5%. So whenever you get a 2x2 table, you should absolutely be able to calculate the test characteristics. Those that are prevalence independent and prevalence dependent. You'll get a sense as to why I mean prevalence independent and prevalence dependent as we go through this. But just keep in mind that I'm going to keep saying that. So now what do? We just got that study, and it gave us the test characteristics, right? 50%, 83%, 75, and 63%. What do we do with those numbers? Well, just like we did in the Bayes example, we modify our probability based on things that happen in the intervening time. It can be the passage of time, it can be further data gathering, and in this case, it can be a test result. So we start out with our pretest probability, we come up with our test result, we find out was it positive or negative, and that changes the post-test probability. It changes the probability of the disease. But where do we get these numbers from when we're talking about an individual study? Well, the first thing to keep in mind is I've been saying this concept of prevalence. Based on this study here, A plus C over B plus D, where is prevalence captured? The prevalence of the disease in the population being studied? Think about it for a second. It's actually up there. The prevalence of the disease being studied is captured in the sum of the first two columns. Remember in that first study that we were talking about, there were 150 patients that had the disease and 150 that didn't? That would correspond to a disease prevalence of 50%. In that particular study, in that particular article that we're reading, the disease prevalence would be 50%. That's absolutely critical to keep in mind. The reason it's critical to keep in mind is that your ability to take that data and apply it to the patient that's sitting in front of you is totally dependent on whether you think that patient represents the average of the patients in that study. Would that patient be would that patient have been included in that study based on the average characteristics of the patients in that particular study? If they are, then you can absolutely apply those characteristics to that patient. If they aren't, then you have to do some manipulation. And I'll take you through what we actually have to do. So as we talked about, the prevalence in this particular study was 50%. We can calculate that from the actual study itself. But in order to understand what we do with the patient versus what we do with the study, which is a study of populations, we have to accept the fact that in the population view, the prevalence reflects the number of people with the disease at a given moment. Remember I said all diagnostic studies are cross-sectional studies? Well, that's exactly what's happening here. But at the patient view, we have to understand that the same concept implies how likely an individual patient has a disease. In other words, my pre-test probability for a patient of having the disease before I get the diagnostic study is exactly analogous to the prevalence of that disease in the population being studied. Why is that the case? Well, let's just do a mental example, do a hypothetical example. If I took that patient, remember we did our clinical prediction rule, 35% pre-test probability, right, before we got the test. If we took that patient and cloned him or her, or in this case him, 100 times, how many of those patients would have the disease? 35. 35 of those 100, if we cloned that patient 100 times, 35 of them would have the disease. All right? That's essentially taking that patient and trying to figure out, well, if we cloned him 300 times, trying to get analogous to the study that we're looking at, how many of them would have the disease? Well, in that case, it would be about 105 of them. Well, we have a study that has 150, and we have a patient where it would have been about 105. Can we use that study exactly in this patient population? The answer is not quite. We have to do some manipulation. I'm going to show you how we do that manipulation. But that's the concept of the populations and patients in order to be able to figure out what we need to do next. So we take the disease prevalence. That is what is analogous to our pretest probability. But our test result has to come from the study itself. But it requires us to have a very important assumption. And the question is, the test characteristics that we get from a study. And when I say test characteristics, I don't mean post-test probability, predictive value. I don't mean predictive values. I mean sensitivity and specificity. The assumption I'm going to ask you to remember, are test characteristics fixed? Yes. Sensitivity and specificity are constants. Meaning that if you were to do that same study with a different patient population, meaning instead of 150 and 150, you actually had 100 and 200, or you actually had 500 and 2,000, affected and not affected, your sensitivity and specificity should generally come out the same. Your predictive values will drastically change, but your sensitivity and specificity should come out the same. Yes? Correct. Yes, that's right. And rather than saying that the pretest probability and the prevalence are the same, they're analogous concepts. But keep in mind that they really are analogous concepts. They're not exactly the same, but it's the same conceptual underpinnings. There are exceptions and caveats to the assumption that sensitivity and specificity are constants, but they are far beyond the scope of this course. So for this course, just assume that regardless of which test you get, which study you look at, the sensitivity and specificity for a particular test should be about the same. So if that is the constant, that will be analogous to the test results. We will get a certain test, and we'll use numbers from sensitivity and specificity to then figure out how the probability shifts. Let me take you through an example of doing that. So now we're going to get into the weeds with the numbers. I apologize for getting into the weeds with numbers, but it's important to see this from the standpoint of a 2x2 table. So in our study here, this was the study, we had a prevalence of 50%. Here's the 50%. We already calculated that the positive and negative predictive values are 75 and 63% based on the sensitivity and specificity of 50 and 83%. So the question I'll ask you is, how did the predictive values relate to our probability after the test result is obtained, our post-test probabilities? So we started with 50, and we came up with positive and negative predictive values of 75 and 63%. Well, the answer to that question is that they are related. They're absolutely related. Let me show you how. If our pre-test probability in this particular study was 50%, remember the average characteristics of the patients in this study should have had a pre-test probability around 50% because half of them had the disease, half of them didn't. And we got a high probability VQ scan, a positive test. Then the likelihood that they really have the disease, the average person in that study, is 75%, the positive predictive value. You started out at 50, you went to 75% because you got a positive test. Again, this is for the average patient in this particular study. If you got the opposite, if you got an other VQ scan test, meaning that the other category, essentially a negative test, the question I would ask you is, if you started out at 50% and you got a negative study, what is the likelihood that you have the disease. Don't jump to 63%. Actually what? 37%, right? Because 63% is the likelihood that you don't have the disease, right? Because the negative predictive value is the probability that you don't have the disease given the fact that the test is negative. So the likelihood that you have the disease is 37%. I say tricky there, but that's not that tricky. Hopefully it makes sense conceptually if you think about it. So if you got a positive test, it was 75. If you got a negative test, it was 37. What did we just do? What we did is we splayed the test results. This is a visual way of depicting the probability shifting. You started at 50 and you moved up to 75%, and if you got a positive test, and you went down to 37% if you got a negative test. Does that make sense? Again, we just took what happened in that particular study. We didn't even apply it to our patient population yet. So essentially what we did is we showed that disease prevalence is analogous to the pretest probability, the sensitivity and specificity are analogous to the test results, and the predictive values are analogous to the post-test probabilities. These are analogous concepts. You can use Bayes' probabilistic reasoning to shift probabilities. You can use 2x2 tables to do it as well. Let me show you what we do now with that particular concept. So now I'm going to ask you to think about our patient. Let's say, again, let's not think about our patient necessarily because we started at 35% with our patient. But let's just say a patient we were seeing had about a 50-50 shot, we were thinking before we got the test, of having a particular test, of having a PE. And we got a VQ scan, and it was a high probability VQ scan. We just learned from this test result, this study, that we went up to 75%. Got the test and it went up to 75%. The question I would ask you to think about is what would you do with that number? And you have, essentially, we have as clinicians 3 choices. We can either treat as if the patient has a PE, we can decide to get another test, or we can decide that the patient doesn't have a PE. I want you to use your clickers and answer A, B, or C. Do they have A, B, or C on their clickers? Yeah. So click in A, B, or C. Look at that. And as you're doing this, think about what factors are going into your mind as you're thinking about this. Okay, so we got 87% here. Let's see what we got. Oh, a nice variation. So we got about 47, these are 47 people that said that you would treat as if the patient had a PE, and 64 that said that you would decide to get another test. So let's unpack that a little bit. Those of you that said that you would treat as if the patient had a PE, what went into your thought process? Yes?
I find it was serious enough to say, even if there's no chance that I'm wrong, I don't want to risk this person having further complications.
Okay, so you built in the seriousness of the disease into your thought process. 75 was high enough. It's a serious enough disease. I don't want to miss it. Okay? Other considerations for choosing A? Yes?
Additional testing might be harmful to the patient.
Okay, so what would that other test be? Another test. Could be more expensive. It's probably going to be the PA-gram that we were talking about, the pulmonary angiogram, the gold standard, which carries with it probably about a 0.5% risk of stroke and maybe a 5% risk of temporary renal failure. So not insignificant risks that are there. So you'd be weighing the risks of the other test. Those of you that said B, again, A and B, there isn't a right answer here. So those of you that said B, what went into your consideration? Yes?
Possible risk of treatment overall.
Ah, so the risks of treatment. So what is the treatment that we would be placing on this patient?
I have no idea.
Probably, but it sounds dangerous, right? Yeah. So it's anticoagulation. And anticoagulation carries with it bleeding risk. So you would be absolutely weighing the risk of just jumping in with the 75% and treating the patient. Absolutely. Any other considerations? Yes?
Are alternative options, if one of the other options, can the treatment exacerbate that condition?
Ah, so now as we're thinking about it, well, 75%, we still were thinking about CHF and asthma and COPD. If we treat them, would that delay our diagnosis? So the delay in diagnosis of alternative diagnoses is actually a real issue. Let's say we were thinking about myocardial infarction, a heart attack. If we focus down this path and start treating them with anticoagulation, are we going to miss something else that could be even more important and life-threatening if we miss? So those would be all considerations that you would weigh. Great. This is the sort of discussion that you would be getting into as you're thinking about this. Now let's go to the other side of the coin. Let's say in that patient who had 50%, you got the test and it was actually a negative test. Remember, we went from 50 to 75 if it was positive. We went from 50 down to 37 if it was negative. Now tell me what you'd want to do. Okay, we're at 80%, 85% response rate. Here, there seems to be a bigger consolidation of opinions around B, deciding to get another test. But there are a few of you that felt that 37% is low enough. Those of you that said B, why would you get another test at this point? Why not just say that the patient doesn't have a PE? It went down. Yes? So that doesn't seem low enough, is what you're saying. But you're also building in, the reason it doesn't seem low enough, if I was talking about the common cold, would a third be okay? A third might be okay, especially since we don't have really great treatment for the common cold. But a third may not be okay to completely exclude for a PE because you're saying that the disease may be serious enough. Okay, that's a consideration. Other considerations? Yes?
Well, it's close enough to our gut feeling from the very beginning, so it didn't really help us narrow it down.
Didn't really help us narrow it down, although we started at a different starting point. So I'm going to put that off to the side. But let's say that guy had a previous history of DVT. He would have been up at 50%, remember? So let's say he was at 50% and we went down to 37%. It doesn't really change our thought. We're kind of treating 37 and 50% around the same levels, what you're saying. Okay?
Even though it's less than 50%, it might be the disease that carries the biggest probability right now.
So you're still thinking that the alternatives may be lower. Although keep in mind that those aren't independent phenomenon either. As we start going low here, you're inherently going to be thinking, well, maybe emphysema is climbing up. Maybe heart failure is starting to climb up a little bit. So that will go through your mind as you go through this. But keep in mind that those are all very worthy considerations. So as you start thinking down here about whether you're going to test or pursue a different diagnosis, which is what you would do if the patient doesn't have a PE, if you thought that they didn't, is based on what is the likelihood of missing that particular disease and how serious is that as a possibility. So, based on that, again, I'm going to give you what the general consensus answers were. Treat as if the patient had a PE. 75% in general, when this was an actual scenario that was sent to a number of physicians as part of a study. The majority of them treated at 75%. And the majority of them decided to get another test at 37%, using exactly the rationale that you unpacked. So look at that. First month of medical school, and you're acting like mature, sophisticated clinicians. What do you need to go to lectures for? However, what if we were to change our pretest probability? Remember, we were talking about what did we do before? Well, so now the question becomes, you have this study that focuses on 50%. What if we had a different pretest probability? How does that change what we do? Well, the answer is that it can absolutely change our numbers. Remember, I said that probability and the predictive values are completely related to where you start, what the disease prevalence is. Well, if we started at 50% and we called that a high risk, but we are going to now say, well, suppose we were dealing with someone that was a little lower risk. How would that change our decision-making process? Well, let's see. The fundamental assumption is that sensitivity and specificity are fixed. So just because we're changing the prevalence of the disease in a different study, you don't change the sensitivity and specificity, because the assumption is if you did it in a lower risk or a higher risk population, lower prevalence or higher prevalence population, that the sensitivity and specificity would stay the same. But we have to recalculate our predictive values in order to figure out how our probabilities shift differently. So remember we talked about high risk being 50% and it went to 75 and 63%? That happened here with this 2x2 table. What I'm going to ask you to do is if you change the probability, what you need to do is conduct a hypothetical new study. In your hypothetical new study, your prevalence is now 25% because that's your new pretest probability. And in that hypothetical study, if you had 300 patients, you would find that there would be 75 patients in the disease group and 225 patients in the non-diseased group, right? A quarter, 3/4, if you're talking about 300 patients total. So the sum of this column should be 75, the sum of this column should be 225. But your test characteristics are the same, which means that of all the people who have the disease in this study, the percentage that would test positive is still 50%. Your sensitivity is still 50%. Therefore, 50% of that 75 should be your true positives. That's 38 and 37. I gave an extra point to those, to the true positives. Of the 225 who didn't have the disease, 83% of them are going to test negative because the specificity is absolutely the same. That's the assumption. By doing that, you'll find that 187 patients are true negatives and 38 patients are false positives. Once you have created your hypothetical 2x2 table with the new study where the low-risk patient is actually the average patient in that study, you will now be able to calculate again your positive and negative predictive values. Your positive predictive values, notice, drop. Now, half out of your positive tests, half of them are true positives, half of them are false positives. Your negative predictive value got better. You'll see that out of these 224 patients who tested negative in your new study, 187 of them truly don't have the disease. Your negative predictive value was 83%. So this got better, but your positive predictive value dropped. What's happening is as you do the same test on a lower risk population, you're getting more false positives. That should conceptually start to make sense as you work through the problems for tomorrow. So if you start at 25 and you get a VQ high other, you're now down to 17. And if you get a VQ high, you're up to 50. So now use your audience response system. Let's say now you're up at 50. You started at 25, you went to 50. Now what are you going to do? Same three choices. You either treat them as if they have a PE, decide to get another test, or decide that the patient doesn't have a PE. So much more of you consolidated around getting another test. If you thought that 50% wasn't good enough last time, you probably should be thinking that 50% is not good enough this time, that you need to get another test. But it may not. It may vary from circumstance to circumstance, but that's probably why you guys are consolidating around B. What about this consideration? Now you've gone from 25 down to 17%. What's your decision here? Do you treat them as if they have a PE? Do you still need to get another test? Or do you decide that 17% is low enough? Most of you decided that 17% is low enough. And that makes sense. Still may not be. Some of you still are a little bit uncertain that this disease is still one of these can't miss diagnoses, and that's reasonable as well. So this is what the survey showed, is that out of 50% was not high enough to treat as if they had a PE and we needed to get another test. But interestingly, the vast majority of our clinicians said that 17% was not so low as to eliminate PE. And now, unfortunately, that's the reason that you actually have to come to medical school for the next 4 years. Because this is classic of what's happening. What's happening with clinicians is that we've been burned. We've sometimes missed a PE. And when that happens, how does that influence our subsequent decision-making process is a critical area of study. Because we're not robots, we're not computers, we're not totally wedded to the clinical prediction rule. We're not totally wedded to those 2x2 tables. We're using our clinical judgments. And I can guarantee you that the physicians who said that 17% wasn't low enough had all missed a PE at some point in time. I certainly have missed a few. And they're worrisome. So not all of this is numbers. The numbers help guide you, but they don't do everything. Let's change it again. Let's get really low risk here. Now we're talking about a young woman, no risk factors, some dyspnea, no history, no risk factors, normal exam. If we consulted our clinical prediction rule on this, we would find that her pre-test probability was about 5%, really low risk. And if we went through our 2x2 table and created a hypothetical study, we would find that 15 patients would test positive, would have the disease. 8 and 7 would be true positives and false negatives, and 295 would not have the disease. But using the fixed test characteristics with specificity of 83%, 47 would be false positives, and 238 would be true negatives. Now look what's happening. Now all of a sudden your false positives are driving the numbers. If you get a positive test in a very low risk individual, it is overwhelmingly more likely that that is a false positive. Even though it's the same test result, you still got a VQ high probability. But because of the numbers and the way things assort, and because of the test characteristics, which are reasonably fixed for a wide range of pre-test probabilities, you are much more likely to have a false positive with a positive test than a true positive. And so your positive predictive value is only 15%. So while here with 50% you went up to 75 and 37, with 5%, you really only go down, you only go up to 15% with a positive test, and you go down to 3%. The question you should be asking yourself is, in this case, why did I get the test? If by going up with a positive test I only went up to 15%, which most of you said would be low enough to say you didn't have a PE, why didn't we say it was low enough not to worry about a PE to begin with? And if we got a negative test, we only went from 5 to 3%. Don't tell me that our level of granularity in our decision-making process is so finely tuned that 3 versus 5% makes a difference of whether we're going to treat someone or say that they don't have a PE. Unfortunately, as physicians, we actually do this a lot. We order tests, and then we get the test results back, and we ask ourselves, ooh, why did I get that? Now I'm stuck. Now I have to have a conversation. Now I got to figure out the next test. Now I have to create anxiety in my patients. Those are real issues that we deal with, and they're captured partially by the numbers that you see here. So the key fundamental observation is as prevalence and pretest probability decreases, positive tests are more likely to be false positives. Risk drives our interpretation of test results. It's a fundamental concept that you will see everywhere, whether you're dealing with a genetic test, whether you're dealing with a sophisticated, high-expense, high-risk test, or whether you're just asking another question to a patient. You are not going to ask all questions to all patients in your history taking. You are going to eventually start to target certain questions for certain patients based on what's going through your mind as it relates to your differential diagnosis. That's the same concept. If you ask the same questions to all patients, we would get a lot of noise, and we wouldn't be able to decide how we should be thinking about disease states that are happening in our patients. So fundamentally, if you could answer this question, you've gotten the take-home point from today. If you get a high prob VQ scan for the diagnosis of PE, is it more likely to represent a false positive test if the patient presented with many clinical features of the PE or no clinical features of a PE? It is more likely to represent a false positive if you're dealing with a low-risk patient. If that concept makes sense and you can understand it at a numerical level and a conceptual level, then you're on the right path. Now, in the last 5 minutes, I'm going to give you a bunch of other ways that you can look at this same concept. Remember, I said that Bayes is one method to manipulate shifting probabilities. 2x2 tables are another way to numerically capture shifting probabilities. There are also likelihood ratios. Now I'm going to introduce likelihood ratios here. You can choose to use them if you like. Some people really like them because they're simple and straightforward. Some people don't like them because they don't dive into how the complexities of the concepts as easily. But if you like them, use them. And it's an advanced concept, but I feel like it's important to at least introduce you to here. Sensitivity, you remember me saying, is the percentage of people who have the disease that test positive. That is the true positive rate. That's another word for sensitivity. Specificity, remember I said, is of the patients who don't have the disease that's the percentage testing negative, which means that if you have a high false positive number, then your specificity is going to go down. So specificity is exactly analogous to the false positive rate. Actually, 1 minus the specificity, which captures that other box, the false positives, is your false positive rate. So you can actually look at relationships between sensitivity and specificity. True positive rate, false positive rate. Same thing with the negative rates. Your specificity is the percentage of people who don't have the disease testing negative. That is your true negative rate. But if you're looking for where's the false negative captured, well, it's actually captured in 1 minus the sensitivity. Because if sensitivity is the percentage of people who have the disease testing positive, then the people who have the disease that test negative are going to be your false negatives. If you have a high false negative rate, your sensitivity is going to go down. So your false negative rate is 1 minus sensitivity. So that's a definitional slide. But you can actually combine those two concepts in likelihood ratios and what we will call receiver operating characteristic curves. Again, beyond the scope of being able to understand in a single 5-minute component of this lecture, but certainly something you can explore in your small groups. Likelihood ratios is one way to combine this. Likelihood ratios depict the relationship between true and false rates. So if you were to put a ratio of the true positive rate over the false positive rate, that would actually be the likelihood ratio for a positive test result. And here's how it's captured. Sensitivity over 1 minus specificity. If your likelihood ratio is greater than 1, then that means a positive test will increase your likelihood of having the disease compared to when you started before. If you have if it's better than 10, it's a really good test. And if you run through the calculations with some hypothetical sensitivities and specificities, remember that these are percentages, so we're talking about 0.83 for a specificity of 83%. If you were to plug them in, you'll see that a likelihood ratio of 10 is really good. A likelihood ratio for a negative test is done by putting the false negative rate over the true negative rate. So it's vice versa. We flipped it over in order that we're not talking about the same numbers scale. So if the false negative rate is smaller than the true negative rate, then you'll have a less than 1 likelihood ratio for a negative result. And if it's 1/10 of the true negative rate, you have a really excellent negative likelihood ratio. Again, run through them and you'll get a sense of how they relate to each other. Well, how do we use them? Well, what we do is that we can combine our likelihood ratios with our pre-test probabilities in order to get our post-test probabilities. People like this because they don't have to do a 2x2 table. I am sort of neutral about this at this point because I think the 2x2 tables help visually capture what you're talking about. If you feel comfortable with the 2x2 tables and what it's conceptually offering, then you can absolutely move to likelihood ratios. You guys can get a sense of where you're at with this. So let's say we use our likelihood ratios for a high probability VQ scan. We knew that our sensitivity was 50%, our specificity was 83%. We use the likelihood ratio for a positive test, that's 50% over 1 minus 83%. We come up with 2.9. It's more than 1. It's not 10, but it's more than 1. What that means is that your odds will go up by 2.9-fold if you get a positive test, from the pre-test to the post-test. I use the term odds. I didn't use the term probability. If you've ever been to a casino or a racetrack or rolled a dice, you will know the distinction between odds and probability. But I can't say that I'm going to confine learning to those that visit those establishments. So what is an odds? So I'll just say it very simply. An odds is the ratio of the event of interest to all the other events that could be there, not including the event of interest. So if I roll a dice, a single dice, a fair dice, and I'm trying to get a 6, the probability of getting a 6 is 1 in 6, right? Because there's 6 different faces. The odds of getting a 6 are 1 to 5. Because there are 5 faces that don't have a 6 and 1 face that does. You can convert probabilities to odds. You can, if you want to do that, you can. I'm happy to spend some time doing that. What you need to do to use likelihood ratios, though, is convert your pretest probability to pretest odds, then multiply it by the likelihood ratio to get the post-test odds, and then convert it to a probability. Again, totally up to you if you want to do that. But this is how it would work. If you started at 50%, remember our initial scenario, 50%, pretest odds is 1 to 1. It either has the PE or doesn't, 1 to 1. You multiply by the likelihood ratio of 2.94, which is a positive VQ scan, you get a post-test odds of 2.94. If you were to convert that, it works out to, guess what, 75%. Without doing a 2x2 table. You get to the same number. This is an application that you can use, totally up to you. You can also use ROC curves, which is a way of visually depicting the trade-offs between true positive rates and false positive rates. Again, totally up to you if you want to learn this, but we will cover it in concept in one of the assignments. And it can be something interesting for those of you that are interested in understanding the distinction between the two. The most important thing to take away from all of this is recognizing that sensitivity and specificity are not living in separate silos. They're actually related to each other and can be plotted against each other and made useful for you as you try to estimate your shifting probabilities. Again, more in the small group exercise, specifically assignment 3. So our take-home points from today. Research studies give you diagnostic tests, give you test characteristics. They can give you predictive values too, but they're not the predictive values that you can necessarily extrapolate to your patients. You have to recalculate them to understand how it relates to your patients. But your sensitivity and specificity from those research studies are what is most fundamental and what is fixed. The relationships between sensitivity and specificity can be captured in a number of different domains, including likelihood ratios and ROC curves, or just by using the 2x2 table. If you use the tests appropriately, the most appropriate usages occur when your pre-test and post-test probabilities actually significantly shift. If they don't shift significantly, you have to ask yourself, why am I getting this test to begin with, before you get the test? Keeping in mind that if your pre-test probability is really low or really high, it rarely helps that a single test will shift your decision-making process in a meaningful way. Just like the mechanic that we touched on a couple of weeks ago made a lot of diagnostic errors, failing to entertain all possibilities or pay attention to all symptoms or inform the consumer or fail to perform all diagnostic tests. As the clinician, I would ask you to be the anti-mechanic. Think about all important possibilities. Pay attention to the description of all symptoms. Inform and involve our patients. And perform effective diagnostic tests in the right situation. If you do that, then all 4 steps of the medical decision-making cycle will come together, and your Odyssey will be completed. Thanks, guys. So we'll see you tomorrow in small groups. If you have questions, don't hesitate to ask me. But keep in mind that this comes with practice. And so once you practice, if it still doesn't make sense, we'll be happy to explore this more in depth.